AM 1060 WMEL. The views expressed on the following program are those of the hosts, callers, and guests, and are not necessarily those of WMEL staff, management, or advertisers.
This is Joe Steckler, folks, your host for Focus on Helping Seniors. Helping Seniors is a program designed to educate, inform, and connect seniors and those who care for seniors to resources. We have fun on the radio show. It's been running now for 15 years. We hope it'll run for 15 plus more years. I don't think I'll be around to do it, but you never know. The phone number here at the radio station at WMEL 1060 is 241-1060. 241-1060. Note the change, folks. We're no longer WMEL AM 1300. We're WMEL 1060. And that means that we now have a 50,000-watt transmitter, and our area of coverage is just about quadrupled. So the signal's strong, the programs are good, and we need you to listen. The phone number to call Helping Seniors over to the office is 473-7770, 473-7770. And I want to remind you the first half of the show is made possible through some of the following sponsors. Gentiva Home Health Care, the Eye Institute, Solid Bite Dental Implant, Bill Johnson, Elder Law Attorney, this radio station, Wuesthoff Hospital System, Levin Home Care, Ren Care Medical Alert, Atlantic Shores Rehabilitation, and sad to say we lost the sponsorship of the social adult daycare down in Palm Bay. The owner, Bob Weber, passed away 2 weeks ago, and I think that some of you that had attended the social know that Bob did a fantastic job there. He had many new ideas for adult daycare, and it's just a shame that he couldn't be around to make sure his dream came true. He gave up an awful lot to do that. In fact, the truth be known, the man sold his business, invested his business profits into a daycare to help people. And that goes a long way to say about a lot of people that get involved in the home health care business that try to help people. Bob was one of those people that thought out of the box, and he did everything he could to make those that needed care receive a type of care that would be beneficial and enjoyable. So, you might think of him in your prayers sometime because they always help. My panelist today is Dr. Valarde. Dr. Valarde is a general surgeon?
Yes, sir.
General surgeon at Wuesthoff Hospital System. And in talking before the show, we established a connection that his wife grew up in a town that my roommate from college lived in. So he sent an email to his wife to find out if she knew the family. It'd be interesting to find out, doctor, if your wife did know the Trammels. But today, let's just talk about general surgery a little bit. And first, how long have you been here at Wuesthoff, Dr. Valarde?
Well, I've been first, thank you for having me here in the program.
I think
it's
welcome.
Very helpful for the senior community. I've been in Brevard since 2008, so over 7 years already. And in the Wuesthoff Health System, probably for similar time, at least 5 years.
Good.
Yeah.
What we're going to talk about today, folks, is an area of surgery that, in fact, and over all the radio shows I've been doing now for 15 years, I've talked about surgery, but we talked a little bit about hyperbaric surgery. We've talked a little bit about robotic surgery, and we have talked in terms of some other specified or special areas of surgery, but never general surgery. And we're going to cover two primary areas today called general surgery and bariatric surgery. So let's first talk about general surgery, Dr. Valarde. And, there were three areas we wanted to talk about: preparation and recovery, what falls into general surgery, and common ailments treated by general surgery. First, let's just talk about preparation and recovery.
Sure. General surgery pretty much covers bread and butter thing. A big aspect is abdominal surgery. It also includes breast surgery. The preparation usually depends on what type of surgery patients are going to have. Obviously, the most important thing is diagnosis and make sure that the patient is ready and will undergo surgery with no problem. So prevention, it's a big thing for us, and safety, most important.
When you mention the word safety, what do you mean by safety? How do you mean that?
Well, surgery is stressful for the patient, and believe it or not, also for the surgeon. We have a huge responsibility. So we need to make sure that the patient is going to be able to go through the surgery itself. So for that, we have to take several precautions, and one of them is make sure that the patient is going to be able to support the surgery. And the way we do it is we usually communicate with the primary doctor or the cardiologist or the pulmonologist, make sure that the state of health is adequate and that they're going to be able to support the surgery itself. So once we have clearances, the patient, they can go through the surgery.
Let's say, maybe a theoretical case. Let's say there's a car accident and the emergency room group or the responders bring the patient, say, to Wuesthoff to the emergency room, and they need surgery. Do you operate on people that come in? Would you be a surgeon that operates on people that come in through 9/11 type stuff?
Well, that's usually most trauma surgeons, but let's put it this way. If there's an emergency, like a patient that comes with acute appendicitis, or a perforated bowel, and the patient, this becomes an emergency. It's not so much an emergency or an elective procedure anymore.
Okay.
So at this time, we don't have time to do the clearances or the pre-op evaluations or see if the patient can see a cardiologist. At this point, it becomes an emergency. I mean, no matter what, we have to take the patient to the operating room. So at this point, patients need to know that the risk of complications after surgery are a little higher than making this surgery elective. Elective surgery is always better than emergency surgery. So,
like me getting my pacemaker replaced.
Correct. That's going to be elective.
That's elective. Well, no, it's not so elective. If I wait too long and the battery stops out of the emergency mode, then it's just not going to function.
Correct. That'll become an emergency then.
It becomes an emergency then.
Yes.
I remember, Dr. Valarde, when I had my first problem many years ago, in fact, it was 17 years ago, that my heart started thumping in my office, and I didn't know what it was. And we had a nurse there, and she called 911, and they put me in the ambulance to take me to Wuesthoff. And as we're going, my heart did this flip-flop again. And I watched the emergency technician look at that, and I looked at me, looked at his instruments, and I said, "What was that?" He said, "Your heart's beating at about 30 beats a minute." And he said, "We got to get you to the hospital quick." So they did, and in fact, then the doctor made a decision. I wasn't going to go home till I got a pacemaker. So they kept me in the hospital all weekend, monitored me, but I felt safe. I felt safe because I was in an environment that was equipped to take care of me. And this one of the things I hope that our listeners to our show today will go away from the show, Dr. Valarde, with a sense that with the right kind of treatment, the right kind of care, the right kind of observation, and the right kind of preparation, both on the part of the doctor and the part of the patient, we stand a better chance to have a successful outcome.
Correct. And I think that's a very important point. I think patient and doctors should work together, and have a good relation, and the outcomes are much better that way, for sure. There's things that, the patient knows that the doctor may not, and vice versa. So we need to communicate with each other so we have a better outcome.
Well, I would imagine there are certain medicines that if a person is going to 2, 3, or 4 doctors, and I had this happen. I know of cases where people were going to 2, 3, and 4 doctors, but they were not telling each doctor what medications they were getting from the other doctor. So at one point, one man was taking 20 different prescription drugs, and the other doctors didn't know what he was taking. And it has happened when I had command of the Navy home in Gulfport, Mississippi, my last Navy job. And I said, don't you tell your other doctors what medications you're taking? And this guy was in his 80s. He said, no, why? I said, there's a real good reason. And so he went, and I saw him 2 weeks later. I said, what did you ever do about your medications, your doctor? He said, I just threw them all away. He stopped taking all the medications without telling any of his doctors. Now, that was a dumb thing to do, too.
Right. Well, I think sometimes patients may assume that doctors have all the records and all the information already in front of them, but the truth is sometimes we don't. So I think that's when patients can help up. You know, I do encourage patients to make lists of their medications, to do lists of their medical problems, so when they go and see a new doctor or a follow-up, they can show them the list and, you know, see what they're taking. It will help for sure, you know, take care of them.
You just said something that I have heard for the first time in 60 years of doing radio work. You just made a statement that patients should have a list of medicines and their ailments. We always talk about medicines. We very rarely, I have never heard anybody say, carry a list of what's wrong with you.
Very important. Very important. And if a doctor changes the medication, you know, you need to redo that list and update it permanently. And when you go and see the doctor, you give them your list. And in the other hand, if you have an emergency, you know, or God will, nothing happens, but you cannot talk or you cannot breathe, you know, you just handle that list to the emergency room and they will have much more information about you. So very important with allergies, your medical problems, your medications, etc. Very important.
That's extremely important. You know, the responder program here in Brevard County, they got a vial. It's like a white plastic bottle. It's about 4 inches tall, 3 inches in diameter, and it's got a list inside. It lists all your medications and your problems. What you're talking about, it's all on the list if people fill it out. But it's supposed to be kept in the refrigerator because all the responders are trained to look in the refrigerator to see if somebody has that bottle in the refrigerator. It's a fantastic thing. I got the bottle, but I don't have it filled out. Now I know I have, since I'm talking about it, I have to fill it out because my wife is listening to the show, so I know now again I have to fill it out. Right. It makes a difference. You know, there are certain things, Dr. Valarde, we do and don't do. The smart person listens to what the other half has to say.
Always.
We don't always pay attention, but it's good to have the other person watch out what you're doing. Another point that you point out that some of the common ailments treated by general surgery. What are some of the common things that general surgery does?
Probably the most common area that we take care of is abdominal surgeries. You know, basic bread and butter for a general surgeon would be gallbladder, appendix, small bowel, colon. Also, outside of the abdomen, we're talking breast pathology, breast cancer, etc. Those probably would be the two biggest areas. You can probably talk also about head and neck and thyroid disease. But I will say the bulk is abdominal surgery.
Okay. You mentioned breast surgery. Are you trained to do breast reconstruction?
Not the reconstruction. That'll be part of the plastic and reconstructive surgery. That's usually plastic surgery.
Okay.
But we do all the, you know, before the reconstruction.
Before the work.
Yeah,
okay.
We're talking about, you know, benign and malignant disease of the breast or breast cancer. You know, the incidence of breast cancer nowadays is fairly high. So most of the general surgeons, I would like to say all, but most of them, they're all trained to do breast pathology or breast disease.
This is something that wasn't written down on any of our notes today, but I would like to talk about it for just a minute because I sense that what you can say is very important. When we get in the area of breast cancer applies both to men and women.
That is correct.
A lot of people don't realize that my father had breast cancer, and I've been checked. And I know that my dad, he just sort of ignored what was happening to him. I think there's there's a difference in the way breast cancer affects men and women, but there's also a lot of similarity. There seems to be a reticence on the part of both male and female to say, it's better that I have the elective surgery now, even though I've been missing parts of my body. It's still better to be around her. And I kind of admire one of the, there was a very famous actress that had a double mastectomy because she knew she had breast cancer, but she wanted to be there for her family. And she did that. But what kind of advice could you as a doctor offer to listeners, of both men and women, about concerns for, actions to take regarding care of the breast and breast cancer?
Well, I'm glad you asked that question because it is extremely important. Number one, in males, even though it's lower the incidence of breast cancer, it does happen. So I will just recommend, if patients or male patients feel a lump or a growth or some abnormality, just go to your doctor and have it checked. It's not going to hurt you. If anything, it will help you, and go from there. Sometimes an ultrasound could just, give you that quick diagnosis, but just go and have it checked. Don't procrastinate. Don't wait, because it could be a cancer. Definitely, in male population, it does happen. So don't wait. In regards to breast cancer, prevention is the best treatment, and in many other problems, but in breast cancer specifically. So mammograms comes and has a huge role nowadays. It can give you early diagnosis, and it can prevent many serious problems down the road. So you can detect small tumors that could be removed, and you could be cured. We're talking about curing breast cancer here.
Okay.
So if you have a small lump and it's taken out, and you don't wait, and you have your routine mammograms, that is a huge advantage right there. So I do recommend females to have their routine mammograms. They could do it through their primary care or through the GYN doctor, or even their surgeon. So very important, routine mammograms.
It's amazing. Cancer is a topic that we seem to not want to talk about. And you're right, the prevalence of cancer is becoming more pronounced. There was a very courageous person on the television show today. I don't know, did you know that President Carter was on talking about his own brain cancer?
Correct, yes.
Carter made a lot of different impressions on people. But one, I don't think anybody could not say the man is a courageous person. And he never backed down from saying what he thought. But I thought his stance and what he had to say about his own cancer was truly, truly tremendous. How I think it's disease, care of the body is something that we all need to be more aware of. It's just like I started this radio show 15 years ago to try to get a voice in the community to help people realize that there are so many things that we can talk about, things that can help people. But if we don't know about them, we can't get the help. But you make a strong point for early detection and early treatment of cancer, especially breast cancer.
Correct.
So it makes a big difference. What is there anything else that we were talking about? Preparation, recovery. What other thing we're talking about? I'd like to talk just for a second about patient responsibility. We cannot leave everything in the hands of the doctor. The doctor is not a mind reader. And to assume that the doctor takes care of everything, I don't think is always in the patient's best interest. And I think in particular of my brother. My brother was on Coumadin, and he was going to have a pacemaker put in. And the doctor thought that the nurses had warned my brother to stop the Coumadin 3 days before the surgery. Well, maybe the nurse did, maybe my brother didn't understand what she was saying. The end result was when the doctor started operating, he couldn't control the bleeding. And it took him 3 hours to control the bleeding. And he later told my brother, he said, I didn't know if I was going to be able to save your life, Bob. And he said, I felt so bad. But he said, I thought something had been done. And he said, you have every right to sue me if you want to. And my brother said, why would I do that? He said, that'd be very foolish. You saved my life. He said, you did what you thought was right. He said, I'll do what I think is right. So, it was something that there was no problem from it. But my brother made it into something. He should have asked some more questions.
Right. I think asking questions is very important. Be thorough with your doctor. Feel comfortable with him. If you think there may be something that you forgot to tell him, call the office. Talk to the office. Let them know, or even to the doctor. Most of doctors, we're here to help them. That's what we want. So if you think there may be something that it may help, give a call or update or tell him when you're with him. The other thing is that we are very realistic people. We need to embrace our problems. When we were talking about cancer, a lot of patients may be afraid of, if they have a problem, they may be afraid of knowing what it is. And sometimes they don't know, they don't want to know, and they don't go to see the doctor until it's too late.
Okay, we got to wind it up. We're going to make show break, folks. I read the time wrong here, but I'll let Dr. Valarde finish up what he was saying after we come back from the break. Come back, we're going to talk about bariatric surgery, so do stay with us. We'll be back in about 3 minutes.
AM 1060 WMEL.
We're back live, folks. This is Joe Steckler with the second half of Helping Seniors radio show. I remind you again, our purpose is to inform, educate, and connect seniors to resources. My sponsors for the second half of the show include Senior Scene Magazine, Hometown News, Spotlight Magazine, Seniors Helping Seniors, the Fountains of Melbourne, Beth Courtney of the Braswell Financial Team, Canadian Medications, Wiedemann Malik Attorneys, Vitas Hospice, and Peaceful Beach Mediation. My guest today is Dr. Valarde, who is a general surgeon from Wuesthoff Hospital. In the first part of the show, we talked about general surgery. The second part of the show, we're going to talk about bariatric surgery. And I'll let Dr. Valarde tell you all what bariatric surgery is and some of the more common age groups and why it's important to understand that maybe some people do need bariatric surgeries. Other people might need just to control their diet a little bit.
That's right.
So,
bariatric surgery is weight loss surgery. There's different options that patients can take to lose weight. Basically, patients go through the program. We evaluate these patients. They have to meet certain criteria. It's not for everybody. If the criteria is based on the NIH and Medicare, and it's a world criteria that we use. And if the patient has also multiple medical problems, they may meet these criteria, and they will definitely benefit, a lot of them, from the surgery. In regards to the age, the most common age is usually from mid-30s to upper 60s, and then starts, decreasing.
I'm amazed that the age would be 30 to upper 60s for stomach surgery. And what we're talking about is abdominal surgery to reduce the size of the stomach, correct?
That's correct. There's 3 different types of surgeries. One is the gastric band. Probably a lot of the audience knows about it. We put a circular silicone band around the neck of the stomach, which restricts the amount of food that the patient can take, and that's how they lose the weight. Then we have the gastric bypass, very, very popular also. It's an excellent procedure. And finally, we have the gastric sleeve, which we reduce the capacity of the stomach by probably 3/4. So the amount of food that the patient can intake is very, very limited. And that's how patients lose weight. At the same time, which is, in my opinion, more important, is how much the patient has to work with continued diet, continued behavior modifications, doing portion control, and also exercise, being active, and embracing that there's a big problem in the world with obesity. Nowadays, teenage and adolescent obesity is also a huge problem. So we're truly believers that this is a good thing for the community.
I have heard many different thoughts, Dr. Valarde, about eating, diet, sweets, salts, what we put into our stomach, how much we put into it. You mentioned portion control, but is there any type of correlation between, say, a fact that some people get heavy no matter what they do?
Well, I think it's multifactorial. One of the biggest contributing factors to obesity is our diet, with no question.
Well, when you say diet, though, are we talking about the types of food or the amount?
Both.
Okay.
Okay.
Explain that to our listeners.
So when we talk to patients, one of the things is we say, okay, quality of food or the type of food that you eat. The Western diet is based on high carbohydrates, high processed foods, and that on its own it's a high calorie diet, comfort food that just goes down. Carbohydrates, unfortunately, works as a drug in our brain. We go into withdrawal if we don't have some sugar in, okay? And that's when the cravings come. So not only that, but, our stomach empties and you get hungry sooner. So that's why we recommend quality of food, high protein, low carbohydrate, vegetables, fruit, etc. That's as quality of food goes. Then we talk about portion control, which is very important. The amount of calories that we eat nowadays in lunch or dinner is very, very high. We do not need to eat that amount. So we need to restrict the amount with portion control. So that's another big factor. Quality of food and portion control. And that's why the surgery helps these patients control their appetite and helps the patients control the amount. Now, there's also the mental component in which patients still feel the urge to eat something, even though it's a mental problem, which a lot of patients struggle with, and it's the hardest part. They want to eat, not necessarily because they feel hungry. And this is a learning curve, and we try to help these patients. It takes a long time for them to do the change or relearn how to eat. And it's a big problem. Patients struggle, and it's hard to overcome. Not easy at all.
Well, let's say a person does go through one of the 3 procedures that will cause them to restrict the amount of food they put in their stomach. Could that also become a danger if they try to force more into themselves than they normally eat or need?
Yes. Usually after surgery, the first 30 days is when they have to have a strict diet until the stomach or everything heals. After that, if the patient overeats, they could hurt themselves in several ways. Number one, they can stretch the stomach, and eventually they will not lose the weight, which defeats the purpose, really. Okay. So that's a very important point that we, or everybody, points out to the patient. Eventually, some patients, depending if they go to bad habits or to the old habits, they could have different things like dumping syndrome, et cetera, et cetera. But I think the most important thing is it would defeat the purpose of the surgery if you go to high-calorie diet or increase your portion size. So we tell the patient that they have to work hard, they have to do the changes. If they do the changes, that success is very high. There's a 98% resolution on diabetes types 2. There's a 85 to 90% resolution on high blood pressure. There's a high percent of resolution in reflux, urinary incontinence, sleep apnea also.
Well, you're saying that if I reduce the amount of food I put in my stomach and do a better job of my eating habits, I can reduce reflux, I can reduce... I would like for you to talk about it a little more, because this is something nobody's ever really talked about on my radio show. I have not talked about this, Dr. Valarde.
And this is, I'm glad we brought this point, because this is the reason why we do what we do. Most of the patients come and they are taking over 20 medications a day, okay, for the diabetes, high blood pressure, high cholesterol. They have to sleep with a BiPAP machine, et cetera, et cetera. All these medical problems start coming up with raising with obesity. So as the patient loses the weight, they start getting rid of all these medications slowly. Okay. It could take 1 year or 2 years, but a lot of patients, when they leave the hospital, they're not taking one single more shot of insulin, or they don't use their BiPAP machine, or they already reduced their medications by half. So it's very effective.
Why isn't this more widely broadcast in the medical journals? Why aren't there articles in the newspaper about stuff like this? We see all these one-page ads in the paper talking about how these new cures for Alzheimer's, which I don't believe at all, yet I do believe what you're saying, and these seem to be things that the average person can do.
Right, and I think surgery, it's something that not everybody wants to have. A lot of doctors may not believe. I think the community is turning around for good. A lot of primaries do believe now in weight loss surgery. They see the results. They see the patients that are very excited. Patients running marathons now. Patients running the Causeway. Patients being able to travel. It's not only the medical problems, but it's also the psychological component, the physical component. A lot of patients could not even drive or go to see their family, in another state. So I think little by little, one at a time, we're trying to do the changes, as well as many other weight loss surgeons in the U.S. But it's coming around. It's becoming more popular. One of the big things is ask your primary doctor about your options, okay? Ask them about this or other options that you've read and see what they say. If you don't like the answer, go directly to the source. Call us.
Let me ask you a question, though. We're talking about, let's say, let's take the obese person out of the equation.
Mm-hmm.
Can stomach surgery still apply to people, or is there a need for it? I'm sorry, reading between the lines. What you're telling me about the effect on other problems they have, it would seem to me like certain types of stomach surgery at certain points in life might be a way to reduce other diseases.
Correct.
And you don't necessarily have to be fat in order to have stomach surgery.
Well, we have to meet certain criteria. If not, it will not be covered by insurance. And usually it's on patients with BMI over 35. And BMI of 35 it's a high BMI. So these patients are obese. This is type 2. If their BMI is over 40, they're considered morbidly obese.
When you're saying, what is that word you're saying?
BMI?
BMI.
That's body mass index. It's a formula based on height and weight.
Okay.
And puts the patient, on a certain scale.
Okay. All right.
And that's what we go by. If the patient passes a certain BMI or is over certain BMI, and the number is 35, they usually meet criteria for surgery. And they, not only that, but the benefits outweigh the risks by far. It's shown that weight loss surgery reduces the mortality rate and increases life survival for up to 10 years. So, it's very beneficial. Obviously, we have to see if the patient meets criteria, if they will benefit, make sure that, it's more than the risks.
What's interesting is you talked about age 35 up into your upper 60s and sometimes into the 70s. We're getting into the area now, of course, when the ARP classifies people 55 and older as senior citizens. I see a lot of older people that are overweight. And they're certainly not going to die at 55. It may last till 85 or 95. So we're talking about a quality of life, and quality of life not only for the patient himself, but for the family. So why isn't there more recognition about the type of work you do? And I relate that to the treatment of periodontal disease. A lot of people just don't realize the importance of figuring out if they got a disease in their mouth. They think more if I got a cavity or a broken tooth. But it's not the fact that I've got periodontal disease, because that affects other parts of my body. The same thing for what you're telling me with if your body mass index is too high, it could cause so many other problems and other diseases in the body.
Correct. The higher the BMI, usually over 35, the higher the risk patients to have medical problems, including diabetes, which, by the way, diabetes is not only high glucose, it's a systemic problem. So diabetes affects your kidneys, your heart, your vision, etc., your whole body. But I agree. I think we have to do a better job putting the word out so patients at least know that it is an option. And we've been working hard. There's a limited amount of surgeons or bariatric surgeons, so we can do so much, but we're definitely trying to put the word out and let the primaries know that this is an option.
Years ago, when somebody talked about stomach surgery, they talked about staples. Mm-hmm. Do you still do that?
We do. We use staples a lot in abdominal surgery. The staples that we use, it's titanium staples. They're very small. A lot of patients ask, "Well, am I going to beep on the airport?" The answer is no. It's patients do not create a reaction. Do not create an allergy to the staples. Nothing like that. They're very safe. Technology has come a long way. We do this the laparoscopic and also robotically, so patients go home the next day or in 2 days. In the old times when they used to do this, it was 2 weeks in the hospital. So technology has come a long way, and that's why I think it's gaining more acceptance.
That's an area. Let's talk about that, because all the time, probably most of the listeners that are listening to the show will say, okay, they're going to make an incision in my stomach, open my stomach up, and then expose everything else. And there's the fear factor there, infection and everything else. But you just mentioned a couple of key words, laparoscopic, and what was the other one?
Robotic or laparoscopic, minimal invasive.
Okay, but you can do robotic surgery for...
Yes, we can do it robotically. Robotically is pretty much similar technology than laparoscopy. It's still laparoscopy, right. Meaning 4 little incisions. So the advantage is that the recovery time is much faster. The pain is very low. The recovery time is much faster, and pretty much you get a very good surgery with very good results at a very low risk. So that's why, all those surgeries, bariatric weight loss surgeries, are gaining more acceptance because of the low risk and the very good outcomes compared to what it was in the past. So technology has come a long way.
Well, when they did when I had my gallbladder out, it was done with laparoscopic and 3 little incisions. I don't even remember where they were on my body right now, but I know that it was. There was no problem for me. I had no problem for it. It wasn't like when when I had my dissection of my ascending and descending aorta, they cut my whole chest open. I can still feel the wires where some of them have pulled loose a little bit and from that surgery. But I think about what the surgeons went through to crack my chest, open me up, try to do the repairs, and they sewed and glued me as far down into my stomach as I possibly could do it. And I probably would not have survived that surgery had not a guy named Kerry Stowe done the surgery. And he was, I just found out recently that the military was partially responsible for the I guess the development of the glue surgery.
Oh,
I didn't know that. Were you aware of any of that? Well,
we use glue sometimes, but no, I was not aware of that fact. But it's very different, the surgery that you had with a open with what we do now, laparoscopic. I mean, but the way the blood loss is minimal, the recovery and the hospitalization is very low. So it's much safer, I will say.
What else should our listeners be taking away from this general surgery show that we're talking about today? We talked about precautions for general surgery. We got into bariatric surgery. But what could you tell our listeners to say to their friends about maybe some of the people that really are overweight, and they could just simply say, have you ever talked to a doctor that does this type of surgery?
I will say that don't be afraid to talk to your doctor. Never. Bring it up, discuss it. Also, if you are overweight or you have obesity, I think you're not alone. I mean, this is a worldwide problem. Okay, we have to embrace it and recognize it so we can fix it. If not, nothing is going to be done. If you don't do the change, nobody will for you. So bring it up, talk to your doctor, see what options you have. You may not be a candidate, but unless we question or we trying to find out, we will never know. So bring it up for sure.
Yeah. And all the 15 notes that you sent over to me, you had one that said very important. And the very important went on to talk about diet and exercise. As a general surgeon, what do you attach to the importance of diet and exercise that you would like for our listeners to take away from what you've said today?
Okay. Diet and exercise, it's a great tool. Very important to follow it. But unfortunately, it has not shown very good results. But we have to still use them, What exercise does for us, it increases your metabolism, makes you a more efficient machine to burn fat. It also, makes you more active, obviously, and in general, it's good for your health. But it has not shown so many good results. I think obesity also, it's a social problem, environmental problem. So we have to tackle every single aspect of that to be successful, to be able to lose some weight. So, you have to combine all the tools to be able to lose a few pounds. Believe it or not, and everybody knows, it's very hard to lose 1 pound. It could take 3 weeks, and you can gain 5 pounds in 1 weekend. So it's not fair, I understand, but it's reality, so just think about it.
But there's one thing that I note in everything we've talked about today. You're not afraid to talk about obesity. You're not afraid to say that we have the problem, and you're not afraid to say that we need to do something to correct the problem.
Correct.
I personally believe that unless we do more talking about it, more pointing the finger the right way, that we will never fix the problem, Dr. Valarde.
Correct.
But it is a problem that certainly is fixable.
It is fixable. Correct. And we can help, everybody can help, but the patient needs to recognize it, and it's not easy one way or another, but most of the times the patient has to do the changes.
Okay. Dr. Valarde, I want to thank you for being on the show today. We're getting a signal. We're near the end of the show. But Dr. Valarde is going to do a TV show on this, and we'll get that on our website so you can see Dr. Valarde in person. I want to thank you, and thank you, listeners, for listening today. I hope you've enjoyed the show. We'll be with you next week.
Thank you,
Talk
Joe.
to you later. Bye-bye.
Thank you very much.